Hello, everyone. Welcome to our session, Biofilm, Infection, and Inflammation, Addressing Underlying Issues of Delayed Wound Healing with Advanced Wound Dressings. This program is provided by North American Center for Continuing Medical Education, LLC, and is supported by an educational grant from 3M Healthcare Medical Solutions Division. My name is Dr. Chris Barrett. I am a program director for the outpatient wound care programs for the Crozier Keystone Health System in Springfield, Pennsylvania. And I'll be sharing the proverbial stage today with my colleague, Emily Greenstein, a wound care nurse practitioner from North Dakota. We will be answering questions at the end of this session, so we encourage you to chat with us and your colleagues throughout the sessions. A little bit of housekeeping, our disclosures. More disclosures. And so our objectives today, the goal is to not only discuss with you probably the two biggest issues in wound healing today, in chronic wound care and non-healing wounds, is bacterial bioburden and inflammation, and how they really work together. They're kind of like peas and carrots. You can't have one without the other, or you can, but they certainly more than likely go together in one way. And so we're going to talk about kind of an algorithmic approach to how we can determine if your chronic wound is inflamed, infected, if there's a combination of both of those issues. And then we're going to highlight two advanced wound dressings, two therapeutic options with good evidence and good clinical efficacy. And we'll give you case studies really demonstrating how these two dressings work in dealing with this terrible issue. So our discussion today is really going to center around, as I said, probably the most important and studied area of wound care, and that's the period when the acute wound completes hemostasis and moves into the next stage of inflammation. And this process of inflammation it's a period of tremendous cellular activity. So when the cellular components of inflammation, and that's initially your neutrophils, your macrophages, your inflammatory cytokines, your chemokines, your receptors, when all of this cellular activity is in communication, is communicating, and there's homeostasis between the cellular world and the wound microenvironment, this process is called dynamic reciprocity, has been termed dynamic reciprocity. And when this process of dynamic reciprocity is working as it should, then the wound will progress through inflammation onto proliferation, maturation, and wound closure in the expected amount of time. But it's when this process is interrupted that you end up with a stalled wound, a chronic wound, stuck in that proverbial inflammatory stage. But we know inflammation is really not the only barrier. As I mentioned, infection, wound bioburden, and inflammation really go hand in hand. What's really the driver? And that's kind of the question we're going to discuss today, how we really determine what's really the driver to preventing our wound from healing, or if it's a combination. I'm going to probably concentrate a little bit more on the wound bioburden, the infection, the bacterial component as the key contributor to this very difficult and costly problem. And it's really, I guess the question is, how costly is the problem? Well, I'm just going to give you some data that's just can kind of set us up for, kind of giving us some background on this terrible problem of wound bioburden and the cost involved. So let's look at surgical site infections, just surgical site infections. 31% of all wound infections are surgical in nature. And you can see what it does for those patients in a hospital, increasing mortality, length of stay, which again increases cost. Not only is the CDC monitoring this problem closely, but we know that the payers are very aware of this problem, and they're penalizing health systems and physicians if they deem this problem a fault of theirs. So surgical site infections are a major problem, but it's only part of the story. Let's look at what's really happening in the outpatient world, where really the biggest part of the problem is look at the money being spent in the outpatient areas. So this was a study funded by the Alliance of Wound Care Stakeholders, looking at 2014 Medicare data. So we know 6 years later, we know these costs are already higher, but they looked at and it's really a pretty fascinating read because they really dug down and looked at all of the types of wounds that we would see in an outpatient area and the inpatient area, and all of the complications, and added up the cost from, from physician billing all the way past the physician, the hospital, and the outpatient departments, and all of the ancillaries like durable medical equipment. And they found, if you look at the most prevalent and most expensive, are wound infections, surgical wound infections being number one, followed by diabetic wounds and diabetic wound infections. So bacteria is a huge problem, to the tune of approaching $100 billion in 2014 money. So we know that that's, likely very much higher. So this is happening in the outpatient world. Okay. And this has definitely had repercussions, because we now see the penalties that the payers are putting on outpatient wound departments, because they want us to see us, doing a better job at managing this very, very difficult problem. So if we look at, we have a cost issue, but I like to kind of take a term from the Apollo mission, and I like to think of Tom Hanks. Houston, we have a problem. And here's the problem. The wounds that we're treating, these chronic wounds, are really a symptom of underlying inflammation, okay, underlying comorbidities, underlying disease. And manufacturers keep bringing to market more advanced wound healing technologies, which obviously I think are wonderful and certainly needed. And they're very impressive. But as we see, the penalties, as I said, the payers are really penalizing outpatient wound care. Payers continue to exclude all of these new technologies, calling them experimental. And really what we see is they're really retracting the approved indication. So all of our studies that we do, our trials, are typically based on the most common wounds: diabetic foot ulcers, venous leg ulcers, pressure ulcers. The problem is the comorbidities, which are our real world patients, the patients we see sitting in our chair in the outpatient wound department, those patients are excluded from these studies. So unfortunately, the products that are approved, for these patients, they're not approved for the patients that's sitting in our chair. Unfortunately, the comorbidities are the problems we have to treat for these patients. So the model, the outpatient wound care model of focusing on procedures and revenue is not working out. Okay, it's really driving the restrictions we have right now and the changes we have in reimbursement. So if we look, with cost and quality and outcomes becoming really the measuring stick for success in your wound center, for outpatient wound care, and really for the survival of wound clinics, I feel that AWDs that can demonstrate effectiveness against wound bioburden and inflammation can really become your first line strategy, or at least be part of your first line strategy, treatment strategies, your treatment plan to deal with this very, very difficult problem. But here's another problem. So, and this is a challenge for our wound care providers. The wound care, the AWD market has exploded. It's such a busy place. And we know that for new wound care providers, it can be pretty daunting and very confusing, because not only is the money being spent, the billions of dollars, which as you can see is going to continue to rise year by year, but we look at how many categories exist in the AWD market, the advanced wound care market. And there's dozens and dozens of dressings in each of these categories. So the real challenge for providers is trying to kind of weed through all of these products and really pick products that have good quality evidence and that really are effective in dealing with this terrible problem. So the discussion today is really going to highlight, we're going to talk about two dressings in the category, which is, as you can see, in terms of market share, the number one category in terms of volume of dressings and number of opportunities to choose from, and that's in antimicrobial dressings. Okay, and certainly, dressings that treat both infection and inflammation can be included in this category, but we have a lot of choices to combat wound infection and inflammation. So this is the challenge for providers. So before we can jump in and treat wound infection, we really have to diagnose it. We need to understand when to choose a particular product and why, and that really comes down to assessment and being able to determine, is a wound infected? Is there a bioburden? Is the bacterial load affecting wound healing? So how can we do that? And there's different ways of kind of looking at a wound and really kind of different tools available for us. I like the idea of the wound infection continuum. It's been in existence for the 18 years that I've been in wound care, and it's been continually updated. So the IWII and their consensus group, their group of experts in wound infection and diagnosing wound infection, they published their first wound infection consensus in 2008 using the wound infection continuum. It was just updated in 2016. So, what we see different, okay, and what's changed, and if you read through the article, and if you look at the difference between the wound infection continuum in 2008, 2016, to me, two things stood out, okay? And number one is this idea of wound biofilm, okay, which didn't exist, really, the discussion didn't exist in 2008. So if we're going to discuss bacterial burden in 2020, then we have to have this discussion about how bacteria are behaving and how bacteria are functioning in the chronic wound, in the stalled wound, because we now know that the planktonic bacteria, planktonic state, is really not the issue. Bacteria have changed their phenotype and they have a much more difficult problem, and that's called wound biofilm. And the way bacteria exist in that biofilm, which really comprises roughly 80% of chronic wounds. And dressing manufacturers really had to step up and design their products, their antimicrobials, to really be able to deal with this problem, because dressings in the past dealt with what we believed were planktonic bacteria, and that was our issue. We now know that bacteria behave in a different way, and the dressings have to really adapt to this new paradigm, this new way that bacteria survive in the chronic wound. The other change was, if you look at the 2008 continuum and compare it to 2016, you're going to see something missing, and that's this concept of critical colonization. And it's a term used today, but the consensus group in 2016 decided that concept, that term, critical colonization, should be removed from the wound infection continuum, because they could not agree on a definition of what critical colonization was. So we see that as microbial virulence, or the numbers of bacteria rise, we go from contamination to colonization, and this is just bacteria replicating, but they haven't affected the wound healing process yet. But when we step across that line from colonization to local infection, okay, that's the period where the bacterial level is now affecting wound healing, and it's a decision time, okay? And this is where the concept of critical colonization came in, where it's talking about this concept of bacteria now affecting wound healing, but not causing an infection, okay, a systemic infection. So since we removed critical colonization, we're going to talk about local infection. But as I said, when you cross that line from colonization to local infection, okay, what's recommended is a topical antimicrobial. And that's what we're going to be talking about today is, we talked about, we have good quality, lots of dressings, lots of choices. We're going to highlight a good, effective, evidence-based dressing. And this is the time to use it. When we move into a period where wound healing has been affected, the wound has stalled, and we need to make a decision on how we're going to treat that wound. And that's when our antimicrobial choice comes about. So what is local infection? And how, if we took away critical colonization, how does that kind of work into this new idea of local infection? Well, what happens is, we all know, I think we're all, we can all recognize when there's obvious signs of a classical wound infection, okay? When you see erythema and warmth and edema and pus and odor, we know that there's a process going on, that we have an infection and we know we have to treat it. But instead of critical colonization, what we're now terming it is a more subtle change in the wound appearance, okay? A more covert infection. So this is something that takes a little bit of not only experience, being able to kind of read the wound, because like our diabetic population that doesn't normally mount the same infection, the same process, okay, the same obvious signs of infection that we would see with a normal patient. So we look for things like hypergranulation tissue, or that friable, easily bleeding granulation tissue, or pocketing. It's something I've seen very frequently that kind of tips me off to the idea that likely bacteria have affected, is really the driver. And obviously there's inflammation that goes around with that process. But when I see pocketing and you see that epithelial bridging, the wound has stalled, okay, or it's actually gotten slightly larger, and your progress has stalled. That's that covert or more subtle sign that your wound has a problem with bacteria, and we need to address it with a topical antimicrobial. So that's kind of the idea that's replaced critical colonization, something we can understand a little bit more easily, and kind of gives us a guide to kind of really assess when a wound needs that's intervention. But also I mentioned biofilm, because this is a different problem, okay? So wound biofilm and bacteria that live in that biofilm environment are a very, very difficult problem that really require a different type of assessment. So when your antibiotic treatments are failing, or when you provide an antibiotic, your wound is progressing, and then you remove that antibiotic and the wound regresses, okay, or is unresponsive to what you think is the proper therapy, in addition to all the other signs that we talked about with the covert and classical signs, where there's inflammation, there's erythema, there's hypergranulation. These subtle issues have to point you in the direction of wound biofilm. And again, treating wound biofilm requires a more specialized dressing, okay? And the dressing manufacturers have had to kind of step up and design their dressings to deal with this problem. So, I showed you how to assess the problem, and we now know that we need a topical antimicrobial. So we have options. And the IWII in 2016 gave us some options, some good evidence-based antimicrobial options. And what you can see in this list is some are very familiar. So we know that cadexmar iodine, honey, silver, surfactant technology is all available today. But I think we can all agree that over the past several years, silver has really grown to be the primary antimicrobial compound that we use in our advanced wound dressings. And we have a lot of options. So you see silver sulfadiazine, silver nitrate, we know nanocrystalline silver, okay? So these are all, and silver in your dressings, silver with gelling fiber, which we're going to talk about today. So we, again, confusing, a lot of options with silver, but which ones really work? And that's the question, because there's a lot of different types of silver compounds. So I guess the real question is, what's in your silver, okay? So I'm going to talk to you about the silver that I use, okay, that I brought into my clinic several years ago. And it was really an article in Ostomy Wound Management that really kind of tipped me off to something different, okay, something new, and certainly the science behind it piqued my interest. So what is silver oxysalt? Okay, it's a different type of silver. We call it silver oxynitrite, but I want to kind of just very quickly kind of go through the technology and really what makes it different than all the other silvers that we have on the market today. So silver, this compound is a salt, okay, so it's ionically neutral, but in the presence of heat or water or a chronic wound, okay, it's going to dissociate to an oxygen couplet, okay, and that little oxygen couplet up there at the top of the page is something I want you to remember, because we're going to talk about that and the importance of that in a few slides. But I want you to concentrate now on what's happening at the bottom. This is your classic oxidation reduction reaction. So what has happened is the silver atom, and we know that for silver to have an antimicrobial activity, it has to be in the ionic form. So all of the silver we have today, the ionic silver, is in the Ag+1 form. So what does that mean? It means that the silver atom has lost an electron. Okay, so it's been oxidized, it's at an oxidative state, and it's aggressively looking to replace that electron. And where is it going to get it? It's going to get it from bacteria. But if you look below each of those Ag+1, 2, and 3, you'll see an electron potential. Look at that as energy, as voltage, as power or strength. So we see under the Ag+1 electron potential of 0.8, a very small number. But look at our silver oxysalt. Okay, so it's a higher level of oxidation. It's a silver with a higher level of oxidation. Not only do you have an Ag+1, but you have an Ag+2 and an Ag+3. And look what that does to the electron potential. Look what that does to voltage. Look what that does to energy or power. Okay, so what does that look like? So we know that the silver, okay, and this Ag+1, 2, and 3, it's aggressively looking for those electrons to replace those 3 electrons and remove it from bacteria. And what happens when you retake that electron from the bacteria? Disrupts the cell wall, prevents DNA synthesis, okay, and prevents enzymes from doing what they're supposed to do. So you look at this compound and you look at the very bottom, Ag+1, a very, very small voltage, but look what the other two ions get to do, okay? Very, very strong and very, very fast pulls, because when you add them all up, okay, instead of having that very weak Ag+1 pull, we have 3 pulls, which gives it a more powerful and a faster pull, okay? And what that means is you can kill more bacteria at a lower dosage, which, as we all know, with silver, there's a point where it's too much silver absorbed by the body is harmful, is not good. So here's a way of providing less silver, but getting a more effective clinical action. So this is really the novelty, really the benefit that silver oxysalt has, and really the something different than what we see in all the other ionic silvers on the market. So let's look at, another benefit of silver, okay? So we know hydrogen peroxide, reactive oxygen species. So in the wound is important for signaling tissue damage and recruiting inflammatory cells, killing bacteria. But just like proteases, okay, at an appropriate level, it can help with wound healing. But higher concentrations and excessive concentrations of hydrogen peroxide, again, like proteases, can damage cells, destroy the extracellular matrix, and prevent healing. So the beauty of silver oxysalt, and there are several other silver compounds that can do this, have the same effect in terms of breaking down hydrogen peroxide to oxygen and water. And what did I mention? Oxygen. Okay, what does oxygen have to do? What is oxygen going to be able to do with the wound? So providing oxygen to the wound, helping with angiogenesis, regulating growth factors and down-regulating pro-inflammatory cytokines and helping inflammatory cells do a better job in their action. So when you break down hydrogen peroxide, you release oxygen. And silver oxysalt, although not the only silver compound that can break down hydrogen peroxide into oxygen and water, in a dressing formulation, when put into an advanced wound dressing, it was the only one that was able to do this. So if we kind of take that oxygen, again, the anti-inflammatory effect of this silver compound reduces neutrophils, reduces macrophages. So what they also found, because of that oxygen released into the wound, even taking out the infection, putting silver oxysalt into a chronic wound without bacterial bowel burden, without infection, actually stimulated wound healing and epithelialization faster because of that extra oxygen. So that's a real benefit, which really makes this compound very unique. I showed you some of the silver options, the silver compounds that we have available to us. Well, here was a study done in 2015, one of the first studies really highlighting this new silver compound. And what they did was they looked at a lot of those silver compounds that I just showed you and compared it to the silver oxysalt. So what they found, obviously treating planktonic populations of 3 common bacteria, nothing groundbreaking there, but when we took that silver oxysalt compound, what did I say? Dressing manufacturers, what you want your antimicrobial dressing to do is affect biofilm and be very effective against really the biggest problem in chronic wounds is biofilm. Very, very difficult to penetrate. So what they found is this silver oxysalt was not so much able to completely destroy a mature biofilm, but deconstruct it enough so that with good basic wound care, wound bed preparation, good debridement, okay, when you can disrupt that biofilm, the silver oxysalt can prevent those bacterial biofilm bacteria from reforming the biofilm, which is really what you should be asking of your antimicrobial dressings in 2020. But more importantly, look at, as I mentioned earlier, because of the power of silver oxysalts and those 3 ionic pulls, okay, the 3 electron pulls, you can use less and still get a higher. So if we look at the minimal bacterial concentration and the minimal biofilm eradication concentration, we needed 2-fold less of the silver compound, of the silver oxynitrite, to get the same effect as all of these other silver compounds. And that's really the take home. We use less to get a better effect. Okay, and that's our silver oxynitrite. But I guess the question I asked back in the beginning is there another contributor to wound chronicity, okay, the chronic wounds? And we know that inflammation is certainly is it a bigger part, or is it certainly a contributor? And if you really look at it, as I mentioned earlier, comorbidities, aging, hypoxia and ischemia, pressure, not just stress on the wound, but whole body stress, causing whole body inflammation. So we know these patients with chronic wounds at baseline have a lot of inflammation. So the question now is, how does infection and inflammation work into this process together? And the symptoms, how do they differ? And Emily's going to talk to you a little bit more in detail about this, but I'm going to concentrate on this concept of this cycle of infection and inflammation working together to prevent your early stage inflammation, to prevent that wound from moving on through early inflammation, late stage inflammation, onto proliferation, maturation, and healing. It's that cycle, okay? And let's talk a little bit about inflammation very quickly. And we look at the time concept of wound bed preparation and the barrier of infection and inflammation, the recommended interventions, debridement, antimicrobials. But in this case, if we have a non-infected wound that's inflamed, protease modulators are really the collagen is really the indication here. And so I'm going to talk to you about, again, I told you I was going to talk about dressings with good evidence. This is our environment. So we know with the chronic wound that dynamic reciprocity has been broken. So we have a wound stuck in inflammation, okay, excessive amounts of pro-inflammatory cytokines and proteases. So these studies have been done, and here's a study by Brita Cullen, who designed collagen ORC, and looking at venous diabetic and pressure ulcers, high levels of MMPs and serine elastase. Okay, so our protease level is very, very high, and using collagen in an ORC combination or a collagen ORC combination with silver, been around for many, many years, highest level of level 1 evidence of any collagen on the market. Okay, which again, if we're really going to base our interventions on good quality clinical efficacy and evidence, we have it here. So here's what using a protease modulator to bring down those excessive levels of proteases is able to do. The sooner you used it, this is a venous leg ulcer study, the sooner we use collagen ORC in the wound bed, again, irregardless of infection, the sooner we use the protease modulator, collagen ORC, the faster the wound heal. So higher levels of healing, the sooner we used it. You use the collagen ORC dressing. So that's really our two dressings affecting infection and inflammation. I'm going to show you some case studies, but at the end of the day, this is really our goal, to move our wound through inflammation properly, keeping dynamic reciprocity, moving into late stage, into proliferation, and onto healing, using our evidence-based AWDs that we're going to highlight. So here's one of my first case. This was a trauma wound of a patient who had rheumatoid arthritis, so immunocompromised, and was a smoker. So this is when he first presented to the clinic, was seen by another physician. I was asked to consult here 3 months later when the percent area reduction in the wound was only 3%. So my initial impression was there's inflammation and there's probably a bacterial load. So I started silver oxysalt CMC gelling fiber dressing, and this was 11 days later. So we can see already we've changed the environment, that dynamic reciprocity. And within 4 weeks, I was able to transition the patient from the silver oxysalt to the collagen ORC just to move that wound onto healing. One more visit, the patient completely healed. And then, so again, in that 4-week period, I was able to kind of get my trajectory moving in the right direction using that combination of dressings. Second case study, this is very recent for me. Patient referred to me for hyperbaric therapy, was seen at one of my other wound clinics. The DPM was treating this patient with VAC and a silver hydrogel. And we look at our 4-week PAR for a diabetic foot ulcer. We're shooting for a goal of 50%, 22%. So when I first saw him, this was the wound measurements. I started a silver oxysalt daily, eventually going back to every other day as the drainage level came down. But this was in 4 weeks. So we went from 0 to 69% in 4 weeks. Okay, and again, I switched him to collagen ORC at that point to move that wound on the complete closure. And again, that's using that dressing combination. And this is week 6, we're down to 83% PAR. And he was done with these dressings. So that's it for my portion of this presentation. My colleague, Emily Greenstein, is now going to take the podium and finish out, and we'll have some questions later. Thank you very much.
So thank you, Dr. Barrett, for that presentation. So my name is Emily Greenstein, and I'm a certified wound anatomy nurse practitioner at Sanford Health in Fargo, North Dakota. And I'm going to talk to you now about improving your patient outcomes, putting into practice some of those things that we just learned about from Dr. Barrett. First of all, how do we know a wound is infected? We've all had those patients that like to use Dr. Google. They ask their friends if they think it's infected, or they may ask their neighbor to look at something, or their cousin, sister's friend who's a nurse to look at something to tell them if it's infected. But how do we know it's infected as clinicians? So first, looking at clinical signs and symptoms of localized infection. We all know the classic signs: your redness, your warmth, your purulence, any increased drainage. But those signs and symptoms don't always hold true for our patients that have chronic wounds. In a chronic wound, you might notice bright red friable tissue, that granulation tissue that you touch and it bleeds. There may be a new odor to it. There may be a new increased pain that wasn't there before. You might notice a new increase in drainage. You might notice that the wound has started to form little bridges of skin. It may be stalled wound healing. There might be satellite lesions that start to form around the wound. Those are all signs that a chronic wound can be becoming infected. And then it's important to remember that not all red and discoloration skin on the lower legs is cellulitis. You can have chronic venous insufficiency, which presents as cellulitis. The difference is that cellulitis is often unilateral. It's not bilateral. The chronic venous insufficiency is usually bilateral. So now let's look at the basic management of chronic wounds. We often think that chronic wounds are stuck in that inflammatory phase. That was the old way of thinking, or how many of us were taught in school, that chronic wounds, you get injured and it goes through the cascade of healing, oftentimes getting stuck in that inflammatory stage. However, we are presenting the idea of taking a shift from that and focusing on other issues. So focusing on underlying issues that may drive a stalled wound and will promote wound healing. So when we have a chronic wound, first thing, looking at optimal medical management. Is our patient diabetic, and do they have blood sugars that are way out of control? Does the patient have vascular issues? Is there enough blood flow to help the wound heal? And then infection control, making sure that our patients are optimized nutritionally. Is our patient malnourished? Do they have vitamin deficiencies? Is our patient have very low albumins or pre-albumins? And then, of course, controlling those underlying comorbidities. So looking at optimal wound healing. Optimal wound healing itself, or optimal wound care, needs a good algorithm of debridement, offloading if there's any pressure to the areas, the use of compression therapy, and then the advanced topical therapies that we'll talk about. So coming up with an easy way to help clinicians decide what dressings to use when to help control biofilm and inflammation in wounds. This is a decision tree model that was created. So the motto is selecting the right dressing at the right time for your patients. It's a guide to assessment strategy to dressing selection. And we'll go into this in depth. So the first thing that needs to be addressed is that the patient needs an assessment, a complete assessment. So oftentimes non-healing wounds are symptoms of an unaddressed systematic issue for the patient. So a comprehensive assessment is crucial. So that's looking at the complete past history of the patient, any medical comorbidities they may be having, any autoimmune disorders they have, any diabetes, any neurological conditions, and then contributing factors. Is the patient coming here and telling you one thing and then going home and doing a different thing? Any prior trauma to the area, the wound history, how long has the wound been there, when did the patient first notice the wound, what have they done for it, what has worked, what hasn't worked. And then current medications. This is an important one because we all know that there's certain medications that can delay wound healing, such as steroids, your NSAIDs, if the patients are on any chemotherapeutic agents, if they've ever had radiation to the area, any immunosuppressants that they may be on. And then I always ask the patients too if they're taking any blood thinners, so if they're on any Coumadin. Also, it's important to note if the patients have any allergies, could this be a hypersensitivity reaction to something that they have taken? And then their nutritional history. Having the patients keep a food diary is a really good way to see if they are getting enough nutritional intake. Oftentimes, even our obese patients are severely malnourished. They're not getting enough protein intake, so their albumins or prealbumins are super low, so they don't have enough to heal their chronic wounds. And then we're looking at ordering the correct tests. So making sure we're testing neurologically, using the monofilaments on the feet, deep tendon reflexes, and then vascular, looking at their ABIs, their toe blood pressures, transcutaneous oximetry, and then making sure that we're looking at venous insufficiency ultrasounds. One common thing that I'll see ordered for patients when the patients are not seen through a vascular center, they'll often order venous duplex ultrasounds. Well, those only check the deep system veins. So what we need to do is make sure that you're ordering the venous ultrasounds that are checking for insufficiency, so that we're able to see if there's any venous regurgitation in the superficial system, which is contributing to the wounds. And then infection, you want to do tissue cultures, so bone cultures, x-rays and MRIs if there's suspected osteomyelitis, and then the probe to bone test. So once we have assessed the patient, we've assessed their risk factors, their underlying comorbidities, their medications, we want to add a risk stratification. So this is a system that was developed to make it easy for clinicians or healthcare providers to identify patients that are at risk for the development of infections or the development of delayed wound healing. This one idea that has been presented is to utilize the color system similar to the wristbands for fall assessment. So the stratification of white being that they have 0 to 1 of the following, the comorbidities, they have normal blood work, there's minimal psychosocial issues. Then yellow, they're at higher risk, and then red, they have 3+ of those issues that would contribute. The advantage to using a system like this would be alerting other healthcare providers within a larger system of the patient's risk. So this is helpful for our patients who are seeing multiple providers in the same system. The next thing, once our risk stratification has been completed, is to look at the wound itself. So assessing the wound, the first signs of bioburden versus the signs of inflammation. So we want to look at the wound bed, look at the type and amount of tissue present. Is there a lot of necrotic tissue? Is there a lot of yellow stringy fluff? Is the base of the wound very granular? Is it friable? Does it bleed easily when you touch it? And then signs of a bioburden would be an odor. Is that you notice after cleansing the wound? Is there excessive exudate or purulent drainage? And then we're looking at signs of inflammation. Is there increased pain? Is there redness around the wound or localized heat? So these are just different examples of wounds that you really need to do a thorough assessment of the wound. A wound might not always be what it presents as. For example, you have those diabetic foot ulcers that might be through and through. You also have to check underneath and make sure there's not a lot of undermining or tunneling within the wound bed. So once we get the wound assessed, the patient assessed, we have all of our information gathered that we need, we can now look at dressing selection. So the first and foremost thing, though, is the wound bed preparation. So making sure that you're doing an adequate debridement of the wound, removing that necrotic tissue, removing that extra slough and cellular debris that is within the wound bed. Now we look at the patient status, the wound status, and the therapy goals also. When we take all of those into consideration, we can break it down in two categories for the dressing selection. The AG Oxycell and ORC collagen families of dressings should be used as early in the treatment regimen as possible, especially for those patients that we are seeing that are coming to us from another provider. So say the patient has been at their primary care provider getting treatment, just localized topical wound care. They've been trying different stuff already prior up to 4 weeks or more prior to seeing you in the wound clinic. It's especially important for those to get these treatment options early to help control that bioburden and inflammation. So I'll kind of just give you some examples of how to utilize the risk stratification and then the dressing selection guide also to help you decide on what would be best for your patients. This is an example of a 28-year-old male. He had a partial thickness burn to his hand. He had no comorbidities and then no psychosocial issues. So his risk stratification level is white. He has no signs of inflammation. So with this, we would look at doing a standard of care. So moist wound healing environment and then wound bed preparation. In this case, in treatment 2, this is a patient who is a 65-year-old male. He has vasculitis. He has a history of high blood pressure and venous insufficiency. He doesn't have any psychosocial issues. He's still living at home with his wife, taking care of himself. So based on this and the risk stratification, he is a yellow or red level of risk stratification. There's no signs of inflammation. There's non-viable tissue present. Yes. So then we go down to what do? We're going to use debridement. So we're going to debride the wound and prepare the wound bed. And then we're going to use the AG Oxycell dressing. We select the dressing because the AG Oxycells will help to break up the biofilm and bring down the bioburden. And it will also help with some of that wound bed prep by loosening up or breaking up some of that slough. So this is option 3. So option 3, this person is a 56-year-old male. He presents with a traumatic wound. He has a history of high blood pressure, AFib. He is on Coumadin. This actually presented as a hematoma. He has no psychosocial issues, though. So when we look at the risk stratification, he's yellow or red. There are signs of inflammation? No, he does not have any redness around the wound. Is there signs of bioburden? Yes. Is it heavy bioburden, or is he at high risk for the development of biofilm? And the answer is yes. So we went ahead and selected the AG Oxycell dressing. You can see in this case of the patient that the Oxycell dressing was applied. It really helped to break up that bioburden and biofilm, which was easily then removed by debridement. This is an example of option 4. So this is a lady who's 76 years old. She had a traumatic wound on her scalp. She fell off her deck. She had a history of a failed flap. She had melanoma and radiation to the area. She has a psychosocial history of alcoholism and dementia. So looking at that, she would automatically be in the yellow or red level risk. Does she have signs of inflammation? Yes. No, sorry. There's no redness around it. There's non-viable tissue present? Yes. So then we go to, are there signs of bioburden or risk for infection? Yes. She's at risk for infection in the wound because of her history of radiation to the area and her previously failed flap. So the dressing selection that we use in this case is the ORC collagen with AG. And you can see we utilized that, and she did go on to healing. This is an example of option 5. So this is a 58-year-old male who presents with a diabetic foot ulcer. He has a history of PVD and he has diabetes. He has no psychosocial issues. So when we look at him, his risk would be red or yellow based on the stratification. Looking at the signs of infection, there was no non-viable tissue in the wound bed. There was no signs of bioburden. He wasn't really at a high risk for infection. So in this case, we decided to go with the ORC collagen dressing to just help bring down that inflammation. So now that we've seen how to utilize the risk stratification, how to utilize the dressing selection guide, we need to remember that we need to assess and record wound progress at intervals of every 2 weeks. So if something's not working after 2 weeks, we need to go back and look at that and consider other factors or something that we're missing. Asking the patients, has anything changed? Is there anything new that you're doing at home, or have you added something? And then just remembering, studies show that 50% reduction in wound surface area after 4 weeks is a reliable indicator for if the wound is going to heal or not, if looking at the healability of the wound. And then if there's no changes, we need to further document barriers to healing. So that means, what are our barriers to healing? Is it because the patient can't come off of some of their medications? Is it because they are not able to take care of themselves, or do they not have a caregiver who is able to take care of themselves? Looking at all the barriers to healing, so psychosocial as well as pathological. And then we need to consider any further diagnostic testing that might need to be done. Looking at perfusion, if it hasn't been done, oftentimes our patients will present with mixed disease, so meaning that they may have both the venous and the arterial component going on. And then remembering appropriate cultures, taking biopsies. Biopsies is important, and especially in a wound that hasn't healed, because there is a chance that could turn to squamous cell cancer. So just making sure that we have the appropriate diagnosis and that we're treating it appropriately. And then when we talk about assessing for healability, is this wound healable, or are we looking at something along a maintenance, or are we looking at palliative wound care? And then just remembering that it's never justifiable to leave a wound open to air, especially complex wound care. We need to remember that, going back to the moist wound healing environment. A lot of times we'll have patients that come in and they say that they want to give it some air, or it needs to breathe or form a scab. So just making sure that you're doing a lot of education to your patients and their families, letting them know that that's not always the best treatment, especially in wounds that are chronic. So this is my first case. Dr. Barrett had 2 cases prior to this. This is a patient who presented with a stage 4 pressure ulcer. She was a 71-year-old female. She had a history of a stage 4 pressure ulcer to her anterior shin. She was morbidly obese. She had chronic lymphedema. She was immobile. She was living at a nursing home. She had previously had multi-layer compression wraps. She had used collagen. She had used wet to dry. She presented to our clinic at the 3-week mark. Her wound had been present for 3 weeks. We decided to use the risk stratification. She was in the red risk due to all of her comorbidities and previously failed treatments. We did go through the stratification, looking at the wound itself. As you can see on initial presentation, she had lots of dead tissue in the wound. There was a lot of slough, there was some necrosis. So we decided, based on the algorithm, to go with the silver oxysalt dressing. That dressing was applied and changed every 5 days. And you can see this is when the patient presented and we removed the dressing. The slough and the wound bed is a lot more granular. There was some exposed tendon in the wound base, but you can see by even day 10 that the wound is a lot cleaner. We have a lot healthier looking wound. The biofilm and bioburden has been brought down. The inflammation is down some. There's more granulation. There is still exposed tendon. We did end up transitioning this patient eventually to the ORC collagen, and she went on to healing. Oh, so this is an example of that. So like I said, after 3 weeks, we started the amniotic grafting with the ORC backing on a weekly basis. And then at month 3, the tendon was completely covered, and she was transitioned to a foam cover dressing, and she did go on to healing. So this is case 4. This is an example of a patient who presented with calciphylaxis. So calciphylaxis is a disorder where calcium deposits in the layers of the skin. It's very common in patients who are on hemodialysis. This is a patient who was 62 years old. She was on dialysis. She had end-stage renal disease. She had a history of anemia and cervical cancer. Her treatment plan that we decided based off of the risk stratification and dressing selection guide was that we would start with the oxysalt dressing. Her risk based on the scores, she was a red risk, and we already knew that the wound was biopsied as calciphylaxis, so she was started on the sodium sulfate with her dialysis runs. So you can see in her initial presentation when we did do our initial wound assessment that she did have a lot of slough or dead tissue within her wound base. A wound was not healthy. You can see the skin bridge that's coming down from the top. So we decided to go with the silver oxysalt gelling dressing. We had her change it every other day at home. So this was her initial presentation. You can see on day 30, it was cleaned up. It was smaller. There was no necrotic tissue or slough noted in the wound at all. And then from day 30 to day 45, we did transition her to the ORC collagen. We went with that selection because you can see we want the regular collagen versus the silver collagen because there was really no signs of any inflammation, and she at this point wasn't at a super high risk for the development of an infection. So that was applied daily, and she did go on to heal at day 45.